Hello guys and welcome back to my channel, and in this video we are going to talk about anemia and asthma. So let's see all the case studies related to the KROK questions, and it will be the quick revision. So let's start with the anemia. So first of all, let's see what is anemia. We all know that anemia is simply the condition in which the body lacks enough of the healthy red blood cells, which will cause some sort of fatigue, weakness, because when there is not enough blood supply or oxygen supply is there, so we will see tiredness and a lot of symptoms in the patient. Remember that brittle nail and hair loss is the character of iron deficiency anemia, and I'll highlight some problem with the tongue. They say in the question some sort of erosion or some papillae about they mention in the tongue cases, so that will be the profile of B12 deficiency anemia. So let's see the first highlighting thing. First of all, I want to tell you about the color index. This is how you are going to solve the question. So color index is 0.85 to 1.5. If the color index is low, then it is iron deficiency anemia. When the color index is high, then it is megaloblastic, or let's say vitamin B12. B12 is also known as megaloblastic or hyperchromic anemia, and iron deficiency is known as the hypochromy or low color index anemia. Let's see the ranges of hemoglobin. You can see some fluctuations because data keeps on updating probably most of the time. So in female the hemoglobin is 120 to 160, and in male 140 to 180 gram per liter. So let's see the case studies now. Case study, first of all, we are going to see the B12 deficiency anemia. So in the cases in the cases of B12 deficiency anemia, we are going to see some bright red areas on the tongue. Bright red areas, sir, what are these areas? Sir, they are looking like some erosions. So I'll highlight some photo also in some shots, but just so you know, now I have made it here, that the bright red areas on the tongue are some erosions, and the color index is elevated. As we know that in the color index is when elevated, it is B12 deficiency anemia. You can read all the profile of the question. They say bright red areas, fatigue, lack of appetite, a lot of things will be there. CBC will be affected, and you know that in the cases of anemia you are going to see low RBC and low hemoglobin, and a lot of things. So next case also says about something, glossitis. Glossitis is skin and mucous membranes are pale after tongue inguinal papillae are smoothed out. So this is what glossitis is. Hemoglobin is low, erythrocytes are low, color index is high. Color index means high means what? High is more than 1 will be high, and high means vitamin B12 or megaloblastic anemia. So you can read the question. Next is also the case of color index when given high is the case of B12 deficiency anemia, as we know by the previous questions. It is asking about the what expected changes in the bone marrow function material. So when it is iron deficiency anemia, so we will see the prevalence of megaloblast because it's the iron deficiency anemia. So, right, makes sense. So another symptoms you can see, another question says the bright red fissured tongue. So those erosions are simply termed as fissured tongue. So another symptoms you can see in the question, like loss of appetite, and many things will be there. CBCs will be affected like very highly. Hemoglobin is low, and a lot of things are there. And next, let's see about the iron deficiency anemia. So we know that when color index is low, it's the iron deficiency anemia. Also known as chronic post-hemorrhagic anemia. Sir, why post-hemorrhagic anemia? Because the patient, when lost the blood, he lost the iron in along with the blood due to some reason. So here the patient have the menorrhagia, which is heavy menstrual bleed. So after the heavy menstrual bleed, the patient got the iron deficiency anemia. We can see the you remember about the in the deficiency portion, I have highlighted that the brittle nails, hair or nails, like peeling nails, is the character of iron deficiency anemia. Next is also a case of iron deficiency anemia, brittle hairs and nails, color index is low, and the patient want to eat chalk. So because the patient is having low iron, so sometimes the patient want to eat chalk, sometimes the patient love to eat his nails, or many more products which are not eatable, and like calcium or iron products which are not eatable. So the patient have these urges. This is the symptom of iron deficiency anemia, that the patient want to eat some things non-eatable, which are rich in calcium and iron. Not really. Chalks are not really rich in iron. So the patient want to eat some non-eatable things. This is the character of iron deficiency anemia. Also they say poikilocythemia, so an anisocytosis and poikilocythemia. So anisocytosis means RBC size is affected, poikilocythemia is RBC shape is affected. And also get ready to see in the question the serum iron values will be fluctuated, given differently in the question. Let's see the normal values. Normal values are, in the males iron is 11 to 30 micromole per liter is okay. In female 10 to 30 micromole per liter is okay. Let's see the next case. In the next case the patient says fecal occult blood test positive. So this means the GI bleed. So that's why there will be iron deficiency anemia, or let's say post hemorrhagic anemia after this, right? Another things will be there to mark the iron in the question. So color index is low, hemoglobin is low, anisocytosis, poikilocytosis. So iron is given low, lower than 9.5, although it is very close to normal, but let's say low is low. Data is data. Iron preparation and balanced diet can be provided to the patient as a treatment. The question was asked about the treatment. Next patient says about some transverse striation of the fingernails, which we will see in the cases of iron deficiency anemia, anisocytosis, poikilocytosis, cracks in the corner of the mouth. This is something new. So see the cracks in the corners of the mouth. I'll try to include some photo in the next shots. Here nothing very typical is given, like the color index is not given in the question. So remember about some things, that the nail changes are the character of the iron deficiency anemia. Let's see the next cases. Next case is again about the post hemorrhagic anemia. So the patient was bleeding for 1.5 days, and due to this he got post hemorrhagic anemia. So he lost iron, he lost hemoglobin, you can see he lost erythrocytes, general weakness, vertigo, fatigue, and all of those things you know about them. Visible mucous membrane, pale skin, a lot of things are given in the question. So post hemorrhagic anemia because the patient overbleeded. So next is another case of post hemorrhagic anemia. As you can see, her last menstruation was profuse and lasted 14 days after the previously delayed for 2 months. So it's a lot hemorrhages we can see in the history of the patient. We can see the hemoglobin is low, we can see the pale skin, we can find out the post hemorrhagic anemia easily in this question. Next, here I have highlighted the color index values again. So next patient has a history of peptic ulcer of stomach. So through this history you have to remember that the patient might have bleeded too much. That's why the erythrocytes are low, hemoglobin is low, color index is low. So this is the case of post hemorrhagic anemia. Or let's say iron deficiency anemia, because the patient has lost enough iron. Next is sideropenic. So do not get panic with the word sideropenic, also means the iron deficiency anemia. They say in the question about the sclera is blue. The sclera is blue this time. Instead of getting pale, the sclera got blue. Diagnosis, they say iron deficiency anemia. The question asks about what clinical syndrome expressed predominantly. So this is sideropenic syndrome. We know about the iron deficiency syndrome now. And another things are lesions at the angle of her mouth. So those erosions are mentioned here as well, which we saw in another question. So this is the case of iron deficiency anemia. Remember about it. The erosions we have seen. Hypoplastic anemia. So hypoplastic anemia, let's read the profile of it. There is only one question over hypoplastic I have seen, that the petechial and spotted hemorrhages on the skin of limb and torso. This is given in the question. The lymph node and spleen are not palpable. Pulse this, liver this. CBC, pancytopenia, the question says. So pancytopenia I have explained. A low RBC, low WBC, low platelets. So the bone marrow fails to produce sufficient blood cells This means the hypoplastic anemia. So remember about the case study of hypoplastic anemia. This is easy. Let's go to asthma. Asthma is a chronic inflammatory disease which affects the airway that they lead to the recurrent episodes of breathing difficulties or due to the airway narrowing. So we are going to see respiratory symptoms. Remember that asthma is a expiratory dyspnea condition. Some things which we are going to use in this are Saba Lama. I'll explain them. We are going to see in the patient wheezing. Wheezing means he is not just breathing, but he is whistling while the breathing. Shortness of breath, chest tightness, coughing. This is the triad here. Wheezing, cough, and dyspnea, triad of asthma. And let's see some triggers. Triggers can be allergen, pollen grains, dust mites, some respiratory infections like cold, flu, pneumonia, or viral infections, any other airborne smoke pollution, or exercise induced anemia like physical activity induced asthma can be there. Emotional stress, some emotionally stressed situations can cause some dyspnea to the patients, which will be expiratory, also termed as asthma. So a type of allergens can be allergic asthma. Types can be allergic asthma, non-allergic asthma, which can be caused by not allergen but stress. So exercise-induced occupational asthma due to the chemical and dust due to the occupation. Nocturnal asthma due to the worsen at night due to the cool air, because in the daytime the temperature is fine and hot, and by the sun disappears, the temperature starts to get cool down. So some patients can have short acting beta adrenoceptors and long acting beta adrenoceptors. So we are going to use them in the questions. Let's see some questions. So the first patient is for the status asthmaticus. So status asthmaticus is a life-threatening asthma which doesn't respond to the standard treatment. So even if you give the bronchodilators, albuterol or theophylline, the patient is not going to have any relief. So let's see the patient. Frequent expiratory dyspnea last over 12 hours, failed to respond to theophylline. The theophylline was the standard treatment for these patients. Now the patient failed to respond to this treatment. So this is something what we termed as status asthmaticus. In the seizure portion, I will tell you that when the patient doesn't relax between or doesn't come to the consciousness in between two seizures, that will be status epilepticus, and I'll explain in some another video. So status asthmaticus is here. Next is the patient take 1 gram of aspirin and to treat the acute respiratory infection. After that, he developed the asthmatic fit with the labored expiration that was arrested by the introduction of amiophylline. And the med history says he was with some allergies or surgeries he had for the nasal polyps. Remember about the Samthurst triad. Samthurst triad is any asthma, nasal polyp history, and any sensitivity to aspirin or let's say any NSAIDs. So these are the things you have to remember, that this is aspirin induced asthma. This was the common product or allergen through which the patient start to show the symptom or expiratory dyspnea or symptoms of asthma. A 10-year-old boy with the history of mild bronchial asthma, regular checkup recommended. Simply what we can recommend to this patient having a mild bronchial asthma. Mild stages are really okay. If you just do not contact the allergen, then it will be fine. It will be no problem. However, it's better to keep some emergency treatment along with yourself, like the short-acting beta-2 adrenoceptors. So we never know when we are going to contact the allergen accidentally. So it's better to keep in the pocket the short-acting beta-2 adrenoceptors. So next patient is having expiratory dyspnea, as we know about this, and third-degree persistent asthma. So emergency aid, as I have just told you, emergency aid needs to be given. So keep the short-acting beta-2 agonist or SABA, we say, or salbutamol is also an example of SABA. You have to keep the emergency treatment in your pocket all the time, because you don't know when the emergency will occur exactly. So it is the third degree persistent asthma, so it is severe condition. If the patient doesn't get the treatment on time or the SABA on time, so the patient might die itself if there is nobody to take care. Next patient say about the suffocation attack predominantly with the exhalation. So this is also exhalatory case, and the question screams about they can be relieved by inhalation of beta 2 adrenomimetics or beta 2 adrenomimetics. So they are the short acting beta 2 short acting the SABA they are talking about again. So he is having some expiratory dyspnea which can be solved by the adrenomimetics. You can see the you can read the question of the profile of the question. So this is also the case of bronchial asthma. Next case says bronchial asthma, suffocation attacks occur several times a day. Inhalation of orcifalin. This is something during the last attack. Inhalation of this given no effect. So the patient is not responding the standard treatment anymore. So intensive therapy was unable to stop the attack. So when the patient is unable to respond to the standard treatment, we know that this is status asthmaticus, and by the preliminary diagnosis the doctor highlighted that this is degree 2. So what happens in the status asthmaticus is that the bronchus which we are dilating through the beta through the SABA or LAMA, which we are trying to dilate, so they are completely blocked, so hence they cannot be dilated anymore. So when there is a complete blockade of beta 2 adrenoceptors, then the patient will not respond to the standard treatment. So this is the pathology behind it. Next question says that if there is a patient with chronic bronchitis, so what are the drugs which will be contraindicated in this patient? So a patient with chronic bronchitis, so if we will try to give him beta blockers, what happens is it can turn to a life threatening condition for the patient. So they can cause bronchoconstrictions, right? So beta 2 blockers will inhibit the beta 2 receptors, and they will cause even more problem for the patient, like the bronchospasm. So the patient have contraindicated beta blockers if the patient have history of chronic bronchitis. So the group of drugs contraindicated in this case, taking into account, are beta blockers. So this is it with this video. I hope you are getting my key points, and wait for another video. Have a nice day.